Thank you, sir. Thank you for that prologue for this topic. So with the corona, more and more children getting hooked to the digital use. I think the children with refractive error are the major chunk of our OPD. And so usually whenever I give this talk, I tell that the glass prescription in children, it's not a children play and it's not just science, there is an art behind it too. In adults, it is just the refractive error which determines how much glass to be prescribed in the children. But in case of children, there are multiple factors. Whether there is an associated strabismus, is it an esotropia, is it an exotropia, what is the age of the child, how much age is left for the metropization, any associated amblyopia, what is the vision at which the child has presented to us. So there are multiple factors which we need to look into before we prescribe glasses in the children. According to the JAPOS, any refractive error on hyperopia of more than 3.5, myopia of more than 1.5, astigmatism, a regular of more than 1.5 or anisometropia of more than 1.5. These are the ones which are considered as the amblyogenic refractive error and they have to be prescribed. But then still it varies between child to child according to the needs and demands. Before prescribing glasses, the most important step is the visual acuity. So assessing the vision is the most difficult step in any child when it presents to the OPD. In a non or pre-verbal child, right from optokinetic drum to flag, the most commonly one used will be preferential looking test or the Teller's acuity chart. To the LIA symbols, the K charts, the HOTV, the Snellen. So it extends from OKN to the actual Snellen. And nowadays with the children learning alphabets early, we think we shift them to LIA symbol the HOTV charts quite early, and it does give us an exact visual acuity of the child. Once we get the visual acuity, the next step would be to go for the refraction. Remember, in case of children, they have a very strong accommodation. A thorough cycloplegic refraction is mandatory to get the total refractive error which the child is actually having. So in the cycloplegic refraction, it does range from atropinization, home atropine, cyclopentolate to tropicamide. Tropicamide doesn't have any cycloplegic effect, but then atropine is most commonly used in the younger child of less than 4 to 5, and most commonly when we see a child associated with esotropia, that is when an atropine is being used. If in the school, like now when the school is actually going on and if the child does come to us for a refraction, it is tough to put a homide or the atropine because it renders them, gives them a blur near vision for a period of 1 to 2 weeks. In those cases, a cyclopent refraction can be used where within 10 minutes apart, we use cyclopent, tropicamide, cyclopent, which is known as CTC refraction, and the refraction can be done on the same day and the glasses can be prescribed. Followed by which the best way to assess refraction in any child would be using a retinoscope, which is mandatory when you prescribe glasses in a child to learn retinoscope before prescribing the glasses. Nowadays, we do have handheld automated refractometers as well as our regular AR machines can be used if at all the retinoscope is not available. The next step comes is to prescribe the glasses. Now that we know what is the refractive error, how much do we prescribe? So if it is hypermetropia, what depends how much we prescribe is what is the status of the child with respect to the alignment. Is the child ortho, is the child ESO or exo? So if the child is ortho, most probably a subjective refraction if you are able to do, then we do a fogging. We give the highest plus with which the child has the best vision. Remember here the goal is vision because the child is already being straight in our OPD. But if the child is having esotropia, what we call as refractive accommodative esotropia, where because of hypermetropia, there is an increased accommodation, increased convergence, and that resulting in ESO. In those cases, we basically give them full correction. So we just deduce the cycloplegic value of the cycloplegic agent and give full-time glasses. Here, it doesn't matter what the child is with that number. The child may still be 6 by 18 or 6 by 12. But yet, if the child is perfectly straight, the goal here remains alignment and not the vision. So making the child straight becomes the priority in this situation. Reassess the child after about 2 months. If the child is perfectly straight, well, bang on. It is a refractive accommodative ET, continue the glasses. But if the child is still having a small residual ET for distance and near, then it means it is a partially accommodative ET. That extra amount of the ET has to be tackled by a surgery. But if the child is ortho for distance and more ET for near, that is what we call as high AC by A ratio. Shift the child from the normal glasses to the bifocals, specifically bisecting the pupil. So now coming to myopia, Now, the thing is less than 1 diopter, it is basically, there are children of minus 0.75 diopters per who have come to my OPD and told the blackboard is blur and they're not comfortable. So if it is less than 1, it is individualize the child and do prescribe the glasses, but more than 1 to 1.5 do prescribe of the glasses. The most common way in which we prescribe for myopia, it is opposite of hypermetropia. The least amount of myopic number which the child reads 6 by 6 is what we usually prescribe. But then remember, there are certain situations like if the child is having intermittent exotropias with good control, good to moderate, or residual intermittent exotropia after surgical correction, in those cases we do tend to overcorrect myopia to control exotropias too. And now with children hooking into the mobiles for such a long period of time, cycloplegic refraction is mandatory in all children of myopia to rule out pseudomyopias in the OPD. And never forget retina evaluation. Children as less than as minus 4 diopters per have been noted to have lattices in the periphery, which can be disastrous to the child in their later follow-ups. So progressive myopias, multiple ways are available to tackle. The two most common ones used are low dose atropine, and now the DIMS glasses have been used. That is beyond the topic of beyond this topic. Among astigmatism, the most common thought process was undercorrect astigmats, but now we do correct them fully, give them 6 by 6 vision with whatever the highest number of astigmatic glasses which they are using. Like in myopes, you ruled out fundus abnormality, rule out ectasia. Ma'am has already adequately stressed pediatric keratoconus is a highly missed entity in astigmatisms. Anisometropia, give off the full correction. This is a difference between the children and the adults. In anisometropes, children do tolerate larger amount of anisometropia as compared to that of the adults. So, and in addition to that, amblyopia management is mandatory. Children with special needs, they have accommodative lag. Push the plus, prescribe the plus. It does help them with physiotherapy activities also. Now I told you, this is my last slide. It is not just science, art. It's an art of glass prescription. There are kids who are roaming around with tilted glasses, scratches on the glasses, mother just making the child wear the glasses during the school hours. So these are some things which we need to counsel the parents, that it's not just what the number of the glasses, but how the glasses are worn and how it is maintained is equally important in case of the child. So finally, age appropriate vision assessment followed by that refraction. Give a squint based correction whether it is hypermetropia or myopia, and keep on monitoring the child for future squint and amblyopia, and let's make them see this world better should be our motto. Thank you.
I think very nice, very nice. This is very nice topic. Actually, we are due to shortage of time, and time is over. So, but this is an extremely important topic.
Thank you, sir.
Because the most important thing is that in children it is very difficult to
Prescribe.
first is refraction, then prescription. It is very, very challenging. Thank you so much.
Thank you, sir. Thank you.
And one thing I would just say, like you said, the use of AR in children, but I would still say as manual retinoscopy, if you're good in, nobody can replace a
Retinoscope,
manual
100%. 100%.
Especially for children, because I've had seen my own optometrist in post-traumatic cases. We'll get a lot of post-traumatic scarred children,
Correct.
babies. Okay, and according to that, the vision was only 2 by 60. Now I've done his scleral fixation. He was operated by my senior resident during emergency hours. Now I've done a scleral fixation for that child, and he's 6'9" now. And
True.
according to them, that time he was only 2 by 60 with their APK correction. So if I'd left the child at that moment thinking that my refractionist has done it right, you cannot just trust your refractionist also. Sometimes
100%.
you have to take over in those cases.
No, I think with the pediatric OPD, no
I
matter
think
what.
sometime we doubt we may have 4 or 5 optometrists, but then we will say, okay, this person, sometime, not all the time, but sometime, that okay, children refraction, this person will do better. But very nice.